Thank you, Claire. So 12 months ago, I stood here and talked about body cameras, and in the 12 months since, we've seen a really, really big uptake of trusts, NHS trusts, looking to get credible data on the feasibility of using body cameras within hospital environments. And it's grown massively, so I just want to share a little bit about what's happened over the last 12 months, and again invite you to speak to us out in the hall afterwards about potentially coming to see you and your trust and discussing working with us in a partnership. Very much is a partnership with CALA and Reveal. It's all about getting the credible data, getting staff feedback, patient experience, and sharing that amongst other trusts as well. It certainly isn't a big sales push to put hundreds and hundreds of cameras at this point in time into hospitals. So bear with me, I'd like to sort of explain a little bit about where CALA has come from, what we've been doing, and share some of the experiences of these pilots that we've been doing. I'd like to start with this image. You're probably looking at that thinking, why would a healthcare professional want to use a big body camera like that in a hospital? But this is really where it started. Reveal are really, really successful in the sectors that you see up there: police, prisons, parking, security. And it was about just over 3 years ago that we were engaging with NHS trusts, with their security teams and their parking teams about these body cameras. But a lot of the news at the time was about how the number of incidents of violence and aggression towards nurses and porters and people working inside hospitals. So we just mooted the possibility of using a camera like this within a hospital environment. And the feedback was very much, it's a very big camera, it's quite bulky, it looks more in tune with sort of security, getting the perfect image you can see with the head on the top there. The idea was good. Body cameras could possibly work. We would need to do more work, but that's not really the right product to put in there. However, that front-facing screen is one of the key features to not just this product, but the one that we're also putting into the hospital ward environment. Because the front-facing screen enables the aggressive tendencies. People can see themselves doing it. And I don't know whether anybody in the room has ever been faced with a body camera and whether or not your behaviour has changed. I personally have. Parking warden, I was a bit angry. I was going to chase him up the road and say, why have you put that on my car? And as he turned around, just that motion was enough for me to go, whoa, okay. And I walked away, case over. I certainly didn't give him any abuse. But it's a prime example of how it does work. And you may not think it, but when you are confronted with this kind of image, you are more than likely going to modify your behaviour and not be as disruptive. So here you see the CALA cameras, just bottom corner there. The feedback we got was make it smaller. We did. Make it a more passive colour, not so sort of about evidence. So police, security, they wear like a black or darker uniform. Nurses tend to wear like a lighter blue, white or darker blue, and the white plastic goes really, really well with that. So in terms of that feedback, the camera's been sort of really well received amongst NHS trusts for use by healthcare professionals. You can see that we kept the front-facing screen really because the remit was, we don't necessarily want to capture an incident. We would rather stop the incident. We would rather diffuse it. We would rather, take it from a potentially physical aggression down to a verbal aggression. Or if it was going to be a verbal aggression, just like me when I walked away from the parking warden, if I was going to be verbally aggressive, and I just turned and walked away. So that incident just didn't happen. CALA is the brand name for the camera that you see here that we're putting into NHS Trust for hospitals. Reveal is the kind of the parent company, if you like, much more associated with the security sector. What we're saying here, though, is even though CALA's only a few years old, we've got the backing of Reveal, and we've used the same technology and the same evidence management software that the police have been using for the last 15 years. So it's a really, really mature product. I think there's probably nobody in the room that would disagree with that statement. Healthcare workers don't deserve to be verbally or physically abused. I think that over the 12 months that I've been doing it since the last time I was here, we do sort of hear that staff tend to not be so motivated to come to work if they've had incidents of violence and aggression. So you start to sort of have time off work where the trust is paying that member of staff. They may also be paying a bank or an agency member of staff as well, which would be at a much higher rate. So just something that could keep that member of staff valued and working, we think that the camera can really, really help. So the statement there is that healthcare workers should have more enjoyable days where when you go home at the end of the day, you can switch off and put your feet up and enjoy going to work the following day, rather than that continual sort of level of abuse, whether it be verbal or physical. So why use body cameras? There's sort of 4 or 5 reasons here, which are the sort of prime reasons why trusts are looking to use body cameras. Certainly to de-escalate and reduce disruption. It's proving very, very successful in doing that. And we saw that from the previous sectors. The police report up to 90% change in people's behaviour when there's a body camera present. And we're seeing some of those sort of figures replicated within the hospital environment. The key here is about keeping the patients and the staff safe. It's not just about one or the other. It's about involving the patient in this whole experience and allowing the patient to perhaps request the camera be switched on for a purpose that will suit them. A really good example is at West London, who had a particular patient who was being searched. He was very clever in the way that he got his tobacco and his rolling papers and whatever onto his ward, and he wasn't allowed to. And he would accuse staff when they were giving his stuff back, oh, you haven't given me this back and you haven't given me that back. And it was actually the patient that said, I want the searches to be conducted under body camera. And then from that point onwards, the patient didn't complain about any members of staff. And, you know, they've said we weren't taking anything, but he thought we were. But this has actually put his mind at rest. And there's no more disruption regarding searches from that particular patient. So I think that's a really sort of strong story about how you can involve the patient and make this about their safety as well as the staff that you're employing. Recording an independent account of what happened is, well, picture paints 1,000 words. If you've got somebody accusing you of saying or doing something, or accusing a patient of saying or doing something, if you have recorded that incident, it's very difficult to argue against what you see in black and white. Also to be used for training and learning. So this wasn't necessarily something we thought of at first, but as we visit more and more trusts and they use it for more and more applications, training and learning is a really powerful tool where it's very hard to replicate the emotion of a situation where somebody's been aggressive towards you. You can all go into a training room, yeah, I'll be the patient and I'll shout at you, but it's probably a little bit more laughy, jokey at the time. Whereas if you can actually look at an incident and say, this was a true life incident, you can see the emotion, you can see what was said, we can learn from that. Maybe somebody did something really well and the trust wants to see other members of staff doing, you know, something similar. Look back over the footage. It might be somebody did something particularly not well in the heat of the moment, and we can have a look at those trigger points and say, this is where we could have sort of gone up this path rather than this path. And for training and learning, it's proving to be a very, very popular tool. It does need to be written into policy to be able to use the videos for training and learning. So this is something that we can collaborate with different trusts. We've got a lot of different policies and procedures from lots of trusts who've been piloting with us over the last 12 months, and they're all happy to share those documents as well. This last statement I think is really important. NHSs spend a lot of time and money on sort of training, behavioural techniques, de-escalation techniques, conflict management, lone worker training. When those training tools are used with the body cameras, that's where it's working really, really well. There's certainly not a replacement for all of these other sort of things that trusts put in place. And I talk a lot about how the body camera was assisting in reducing violence and aggression rather than being the one key tool that actually does it. So what I'm saying here is that training is important and it should stay, and we can integrate our body camera with the training that you give as well. So how it works, there's no rule book here, this is how it has to be done. Again, different trusts have got different governance and policies how they want it to be used. But as a basis, this is what we've kind of come up with. Nurse or healthcare worker would see a situation they want to put the camera on. They would announce and make it clear they're recording. Haven't mentioned at this point, but the body camera would not be on all of the time. I think that would be a very difficult product to get into a hospital environment if it was recording all of the time. So the colour camera is switched on when the healthcare worker feels like it needs to, or if a patient requests it. So it might be somebody works for an 8-hour shift and they might only record 5 or 10 minutes of footage, and it might not even be important footage, and that would be deleted eventually. Once the camera's on, continue to deal with the situation until it's resolved. The camera would then be docked and the footage uploaded to a secure cloud account. Unimportant video would automatically be deleted after 31 days to keep it in line with GDPR requirements. Anything important, anything with an incident that you feel maybe needed to be reviewed at a later date, you can put a longer retention policy on it. Anything from the 30 days up to a year, 2 years, 5 years, however long you see fit. Video would only be viewed by authorised members of staff. It wouldn't be a sort of, get everybody into the staff room and everybody have a look at all the videos. It would be like 1 or 2 sort of senior people that would be reviewing these. Video helps resolve situations and get nurses back to doing what they do best, which is giving good healthcare. So there's a couple of case studies. Northampton was the very first trust that we worked with. We put 12 cameras into 5 wards there. Very quickly we realised it wasn't enough because 1 or 2 cameras on each ward just, there was more events than they had cameras to deal with. So we put eventually about 3 or 4 cameras on each ward and they started to capture a lot more of the events. The feedback from staff and patients was positive. Alex O'Neill-Kerr, who is the medical director there, actually did walkarounds on wards whilst the pilot was in place, and he would talk to patients who actually said they felt that the level of healthcare had, was more professional when the cameras were present. So staff were reacting to it as well as patients, de-escalating. Reduction in verbal and physical assaults on 4 of 5 wards. A little bit of an anomaly there. The 5th ward, as it turns out, were not very good at reporting. The culture was that they would accept being sworn at and they would only really record physical aggression. Once they had the cameras, they started to record more incidents and they started to log verbal aggression as well. So actually the verbal aggression went up, but that was only really because they were recording and reporting it all rather than just the physical aggression. Which in itself is a really good thing because we hear a lot of trusts say that they want to improve the reporting culture of the trust. So this really, really helps. It gives them the empowerment of, I've got some proof as to what happened and therefore I'm more confident that something can be done about it. And contributing towards Northampton winning the Patient Safety Award and Trust of the Year for the use of body cameras, amongst other technology and training techniques that they were using. It's very, need to make it clear that it wasn't just body cameras, it was a number of other things as well. You obviously won't be able to read the text there, but there is a feasibility study that we did with Northampton right back in the beginning, about 3 years ago. This is available for anybody to, we can email it out to you. It's really, really good because it outlines why they wanted to do it and whether or not it would be accepted. And once it had been printed and they went ahead with the pilot, we've not looked back. So this is a really good document if you're at the beginning of we want to use body cameras in our hospital type situation. A few comments there, I'll just leave those up there for a second or 2 to read, including the one from Alex that I mentioned. In West London, we did a much bigger pilot. We put about 50 cameras in there over a year. And we also did a research paper with them on the results. So again, we've got some really, really good data which we can share with you. We've got a feasibility study for those at the beginning of a journey, and we've also got the data now from a year case study for those that are really at the point where they want to have a look at getting their own body camera pilot sorted and started. So some key findings there, significant decline in the use of tranquilizing injections. So we had the 3 months leading up to the pilot, they had about 14 tranquilizing injections that they had to use, and in the 3 months after they only had 4. Now Jim Ty, who some of you will know from West London, unfortunately Jim's no longer at the trust, he's moved to another one, but Jim was very instrumental in getting this pilot done, and with his clinical background, he saw the advantage of the product to no longer need all the time tranquilizing injections. So he was very much saying that he felt it would save the trust money and make the patient experience a lot more enjoyable. Again, not just the body cameras, other things that they had going as well at the same time. Staff surveys are really important because you capture people's emotion about how they feel about cameras. Would it be something you'd want to use? Quite often before the pilot starts, you'll have staff say, I don't really know, it might make things worse, I've got no idea, I don't know anyone that's used body camera. Generally we'll then do a mid-pilot survey and then we do an end-of-pilot survey, and this is what helps to build the business case about how staff feel about using the body cameras, and you can see some statistics there. 80%, so 4 out of 5 think that a positive impact body cameras would have. 100% of staff had encountered incidents of verbal aggression at least once a week, and I think that's really compelling. It's basically everybody is experiencing verbal or physical aggression once a week. And they're spending a lot of time dealing with aggressive behaviour, reporting aggressive behaviour, and perhaps investigating aggressive behaviour as well. Just another comment from Stephanie at West London. Again, it's been, she says, a great innovation for them. They've now got, I think, 72 cameras, the colour camera at last count, across about 11 mental health wards. There's a tweet there from Chelsea in Westminster, a member of staff saying, "Thank you for helping me feel safe." It's really great for the trust because the staff feel like the trust are investing in their safety, and it just makes them feel valued. And also the Nursing Times article that we had as well, which saw a 70% reduction in the use of tranquilizing injections. It's just backing up the previous slide there. So I think we're getting close now. There's about 4 or 5 slides left, just about pilots. I'll get through these. Got a little bit of time. Why run a pilot? These are some of the reasons why trusts have said they want us to come in and talk to them about doing a pilot. Obviously, number one, in a lot of cases, is to reduce the number of incidents of violence and aggression, and it really has proven to do that. We've got the data to back it up as well. We want to make the hospital a safer place for staff and patients. It is about staff and patient safety more than capturing the best light and getting the greatest audio and getting a prosecution. It's about stopping that incident before it happens. Using footage for training and learning, increase professionalism from staff. The sort of team you need to put together to do a pilot, the project lead, so the main point of contact for everybody. The person who is going to be getting all the information from your end and all the information from our end and putting it all together. A governance lead, somebody to put the policies and procedures into place. Now, we're really lucky because all of the trusts that we've worked with so far, and there's about 25 that have either gone on to purchase cameras or do a pilot with us. And they've all done their own policies and procedures, and they've all allowed us to share them with other trusts. So if you are that person who's sitting there thinking, "Oh God, I've got to put this policy together," we can give you examples from other trusts, and you can take the best bits out of it, and you can make your own policy exactly how you need it to. So it's really great that the NHS is such a big family and is happy to share all of this information because it can cut down the time and effort that you need to put into it. Really important, the IT lead. In fact, Jim at West London said to me, one of the biggest mistakes I made with our pilot was not getting IT involved from the beginning, because by the time I did, they were a little bit reluctant to help out because they felt it wasn't their project. He said, so we kind of struggled to get it going at the beginning. But IT need to get involved because there are certain things that they need to tweak to allow the Cala service to work and the flow of footage up to the cloud account. So IT are really, really important, and they're definitely my best friend when I get into the trust at the beginning. And a training champion. Cala won't always be around to come and show people how to use the cameras, so usually we look to somebody to be that person who says, yeah, I love the camera, I love using it, and I'm more than happy to show other people how to use it. So that's putting the team together at the beginning. And some of the things that you might need to think about, the equipment needs to be tested ahead of a pilot. So normally we would send out to the IT guy a camera or two, maybe a docking station, so he can test it all. We want to put some ward communications up, so it's really important to let the patients know what's happening, to include them. And what we normally do would put something like this up, an A4 poster, which would have a contact detail on there, so the patients can ask the staff on the ward, why are we doing this, what's it all about, and they can know to expect the cameras to be on the ward in 2, 4, 6 weeks' time. Training as well, so we'd come in and show staff how to use the camera and people how to use the back-end account so they can know how to store and delete and everything, all the footage. And then you decide on the dates. When do we go live? When do we do a mid-pilot review, which is really important. It's a pilot, it's unlikely to work seamlessly from the beginning, so it's great to come in and discuss what's happened and see whether we need to make changes. And then an end of pilot review date as well. These are the things that we've put together in terms of timeframes. And measures. Measures are really important. You can't really do a test if you don't know what you're testing against. So we would always discuss at the beginning what is the most important to you, what do you want to achieve, and what would be deemed a success. For example, if you have 100 verbal incidents within a week on a ward, are you looking to get that down to a certain number? We can put all of those measures in place, and it's great because you can really sort of sense check along the way whether it's working or not and whether you need to change anything. Some of the measures that you might look at would be a reduction in the verbal and physical abuse, the frequency of them. the feedback from the users of the camera, so your staff, but also your patient and their family feedback as well. We have surveys where you can, if you've got long-term patients, and mental health quite often there is, you can involve the patient and their family as well regarding how do they feel about the body cameras. Looking to reduce the number of complaints and the time that you spend on investigating complaints. Quite a lot of time and money is spent investigating when someone points a finger and says this happened or this was said, and if you have that body camera footage, it can really help to cut that down. And the cost of replacing staff. I did mention briefly about, you know, the motivation to go to work when you're being sworn at every day, the cost of having agency and bank staff to cover those. So if we can keep the attrition of staff down and we can keep the sickness down because of you know, less stressful incidents, then it is going to save money. Very hard to quantify, but it will save some money. So engagement during the pilot. Need to keep the staff fully motivated. They're really motivated at the beginning, and it's important to keep that going because you want to have a look at the data at the end and know that it was used properly for the whole 3 months. So we'd look at you guys doing some staff debriefings, maybe once every week or a couple of weeks, getting together and just talking about how it's been working. We'd engage with staff as well during the pilot, a mid-pilot survey, for example. And we can take those opportunities to make improvements or adjustments once we've had those reviews. I like to share success stories as well. I talk about the patient who asked to be searched at West London. And I'll be honest, I told that same story here 12 months ago because it's a really, really good one. But we need more of those success stories. So this is where I talk about a partnership. There's going to be, there's trusts already that are piloting with us, and they've already got some success stories from the first month or two that they've been doing it. So this is where I'd really like to get a little bit more sort of stories that I can go and share with people because they're stories from the trust rather than Callous stories. And we'll certainly learn lessons from doing a pilot to actually rolling out if that's where it goes from there. Reviewing. So we'll just look at those statistics. We'll help build a business case. Calla is on the government G-Cloud procurement framework as well. So there is a procurement route for you. And obviously when we review, we'd look at next steps as well. So really today was just kind of introducing you to Calla, what we've done over the last sort of 12 months and inviting you to kind of talk to us if you are at a trust who do want to sort of look at putting body cameras in and seeing what kind of data that you can get. See whether it's, you know, worthwhile your trust having a look at this. And that'd be the end. So I don't know whether anyone has any questions.